Hello, this is Lorenza, and I will be talking about swelling at the angle of the mandible. Case study is a 14-year-old teenager who presents to the clinic with a chief complaint of swelling to the left side of the face. Her mother is at the appointment with her. The onset of this issue was 4 months ago. She has not sought any medical care because she has no insurance. The swelling is to the right side of the face at the angle of the mandible. It is not painful. It has changed in size since the onset. It does not impede with chewing or swallowing. This is a new problem for the patient. She has never had this before. Her main concern is that it is growing in size and is causing visual deformity to the face. History of present illness. Onset of the swelling was 4 months ago. The location is on the right side of the face. The duration is constant. The character is soft and non-tender. Aggravating factors are unknown. There is no radiation, and timing is continuous. Past medical history. Personal medical history includes patient is overweight and has a history of asthma. She has no surgeries in the past. Family medical history, her mother has diabetes mellitus type 2, and her paternal grandmother had been diagnosed with thyroid cancer, is still living, had a complete thyroidectomy. Medications, she just has her albuterol on an as-needed basis, which she has not been using. She has no allergies. Her parents are divorced, and she lives with mother, and is not active in sports. And all her immunizations are up to date. Review of systems. So the patient denies any malaise or fatigue. She denies any eye drainage, pain, or vision loss. She denies ear discharge, pain, or sore throat, has no difficulty swallowing or chewing, and no change in her taste buds. Denies chest pain, palpitations, denies shortness of breath, cough, or wheezing, denies abdominal pain, change in stools, nausea, vomiting, or loss of appetite, denies any pruritus or rash, does not report any dizziness or sudden onset of headache, does not report having any stress or insomnia, and does not report having any cold or heat intolerance, no hair thinning, and no recent weight gain or loss. And the patient does not report any allergies. Physical exam. Her vital signs were blood pressure 126/80 with a pulse of 76, respiration rate was 12, temp was 98.1, and reported no pain. The patient is well appearing, well nourished, and no distress, oriented to person, place, and time, normal mood and affect, and ambulating without difficulty. Her skin trigger was good, no rashes, no unusual bruising or prominent lesions. Her head was normocephalic, no visible or palpable masses to the head, no depressions or scarring. The eyes, the conjunctiva was clear. Perla was positive to bilateral eyes. Her ears, Pina had no masses, no lesions, no tenderness, no drainage. Tympanic membrane was translucent, and whispered words were heard bilaterally. No external lesions to her nose. Mucosa was non-inflamed. Septum and turbinates were normal. Mucous membranes of the mouth were moist, no mucosal lesions, palpable mass. There was a palpable mass to the right side of the face, firm, non-tender, mobile, and the size was 0.3 by 0.2. Actually, the size was 3.0 by 2.0 centimeters. No obvious dental caries or periodontal disease, no gingival inflammation or significant resorption. The pharynx, so we had non-inflamed mucosa, no tonsillar hypertrophy or exudate. The neck was supple without lesions, bruits, or adenopathy. Thyroid non-enlarged and non-tender. Heart sounds were present, S1 and S2 with a regular rate and rhythm, no murmurs or gallops. Capillary refill was less than 3 seconds. Lungs were clear throughout to auscultation and percussion. Vowel sounds were normal active, times 4 quadrants, no tenderness. Cranial nerves 1 through 12 were normal, sensation to pain, touch were normal. The patient was oriented times 3, intact, recent and remote memory, judgment, and insight. Normal mood and affect. Diagnosis. A working diagnosis is made using the highest level of explicitness and certainty that data allow. The primary diagnosis correlates with the clinical findings of the swelling to the face. The diagnosis that we came up with was localized swelling mass and lump of the head, ICD-10-R22.0. Because we were unable to differentiate if the swelling is indeed a mass, this was the diagnosis we came up with. Differential diagnosis is a process of weighing the probability of one disease versus that of other disease, possibly accounting for the patient's illness. The differential diagnosis that we came up with was parotid abscess, a hemangioma, and a mucoepidermoid carcinoma. Parotid abscess. Parotid abscess is the most common parotid disease in children. Mumps is the most common viral cause to a parotid abscess. Signs and symptoms include fever, headache, muscle aches, tiredness, loss of appetite, and swollen salivary glands. Bacterial sialoadenitis is an infection of the salivary gland caused by bacteria. This infection is uncommon, but almost always involves the parotid gland. Signs and symptoms include pain, tenderness, redness, and gradual swelling to the area. Treatments include antibiotics and surgical drainage. Hemangioma. Most common benign salivary gland mass in children. There are two different types of hemangiomas, cavernous versus capillary. The cavernous hemangioma rarely involves the parotid gland. It manifests in older children, does not undergo spontaneous regression, is composed of large, thin-walled vessels with flattened endothelial cell. Treatment includes surgery, laser ablation, or sclerotherapy. Sometimes it includes all three. Capillary is congenital, 90% of parotid tumors during the first year of life. The soft mass is usually noted shortly after birth. It grows rapidly the first year of life and peaks at 1 to 2 years. Regression of the mass is usually completed by adolescence. It is composed of unencapsulated mass packed with thin-walled capillaries. Surgery is usually delayed because it usually regresses on its own. Mucoepidermoid carcinoma. It is the most common malignant salivary gland neoplasm in children. 35% of salivary glands in children are malignant. 60% are mucoepidermoid carcinomas. Histological patterns includes combination of squamous and mucous cells arranged in cords and sheets. Classifications include low grade, intermediate grade, and high grade. Low grade is smooth, benign appearing at imaging, intermediate hypointense to isointense. High grade is solid, fewer cystic areas, and more homogeneous. And these are usually the findings with the imaging. Treatment usually includes surgical removal with wide local excision plus radical neck dissection for high-grade neoplasms. Treatment plan includes labs, imaging, patient education, and we will talk about the practice guidelines. So CBC with differential will reveal leukocytosis with neutrophilia, and if it is indeed positive, further culture should be requested. A SED rate is also requested just to see what type of infection we are having and how severe it is. TB test is usually done to rule out a TB infection. CT with and without contrast is the imaging modality of choice for pediatric parotid disease. It will delineate ductal stones. Practice guidelines were obtained for the American Family Physician. Pathophysiology of salivary gland diseases. It is most susceptible to infection. The parotid gland is most susceptible to infection because it secretes serous saliva versus mucinous saliva. There are no lysosomes, celiac acid, or immunoglobulin A in serous saliva, predisposing the parotid gland to infection. Factors contributing to parotitis is migration of oral cavity flora through the stents and duct, stasis of saliva, ductal obstruction, decreased stimulation of saliva, decreased mastication, and poor oral hygiene. And these are my references.